Hello, everyone. So we will have two leaders from Atrius Health speaking today on implementation science and healthcare IT. Leading off is Dr. John Zambrano. He's our medical director for our Center of Clinical Research and Implementation Science, as well as a primary care doctor at Atrius Health. And then we have Dr. Craig Monson, who is head of our Center for Informatics and our Chief Medical Information Officer at Atrius Health, and both are experts in their fields and will be giving two separate presentations to help provide some foundational information for this event. All right, so Dr. Zambrano, I can bring up your slides.
Great. Okay, shall we begin?
Go for it.
Great. Thank you, everyone. Again, as Susanna mentioned, my name is Dr. John Zambrano, and I am a primary care doctor here at Atrius, also the medical director for the Center for Research and Implementation Science within the Academic Institute. And the goal of my very short talk is just to familiarize folks with implementation science and raise some awareness around how it could potentially be used by folks in the hackathon as they're thinking about solutions. Before I start, I just want to say that we're excited to work with the MIT Hackathon team as well as with Race to Better Health. And we thank both organizations for their service in addressing racial and ethnic health disparities. And we look forward to our continued collaboration with you guys. Next slide to the outline. Great. Oh, yeah, we can go stay on the outline. Perfect. So this is just what I'm hoping to cover for the day, for today's talk. So hoping to, again, highlight the relevance of implementation science to racial and ethnic, to understanding racial and ethnic health disparities. Talk a little bit about what implementation science is and zoom in to focus on how it's done. And then lastly, wrap up with some takeaways for hopefully the hackathon teams to carry with them over the next couple of days. Next slide, please. Again, want to focus on the relevance, and we can go on to the next slide. So as many of us are well aware, the root causes of health inequities are multi-level and dynamic in nature, involving not just the healthcare sector, but multiple social, political, and economic institutions. As Bailey and colleagues in a recent piece pointed out, root causes often stem from historically grounded harms like African enslavement and Jim Crow, mass incarceration, unequal education, residential segregation, and racist cultural tropes also play a significant role in perpetuating health inequities. And unfortunately, this is not an exhaustive list of factors, but ultimately these do erode health at both the population as well as the individual level. Next slide. Therefore, our solutions must in turn also be multi-level. They should recognize all of these different dimensions at play, and again, try to be reflected, the solutions should try to be reflected in a multi-level sense. I do want to pivot now a little and talk a little bit about implementation science itself and try to make the argument for why it's well suited to address health inequities. So the GIF is up here because oftentimes when I talk to folks about implementation science, most people have an intuitive sense of what it is because most people have implemented programs themselves. And most of us are either in the scientific discipline or well aware of the tools within our scientific disciplines. Next slide, please. And so I won't go into gross detail about all of the definitions, but I wanted to highlight that in the CDC, the NIH, National Cancer Institute, and the Canadian Institutes for Health Research all have their own definitions for implementation science. And what I tried to do here was just focus on the common features. And what the three definitions, the main definitions, have in common are a focus on understanding the process by which evidence-based or evidence-informed strategies are integrated and into routine use. So I just want to highlight that implementation science starts with an evidence-based intervention and really does focus on how to best integrate it, as opposed to proving whether or not that intervention has the desired health impact. And you can go ahead to the next slide. I often find it helpful to take a minute to sort of contrast implementation science from what most of us, I think of as traditional research. Again, I'm being redundant here deliberately because it's really important to appreciate that implementation science is not hypothesis driven. It's not trying to prove that something works. It's starting with something that we already know works. It's starting with an evidence-based intervention. Unlike traditional research, which is very unidimensional in its analytic approach, implementation science is intentionally multi-level in its analytic approach. Compared to research, implementation science explores context, really tries to sink its teeth into context, as opposed to trying to control for context and control for variability. The outcomes that IS focuses on tend to really hone in on process and implementation outcomes, as opposed to health system outcomes like cost and quality, or even clinical outcomes like morbidity, mortality, cardiovascular endpoints. This is really more focused on the process. And then another main difference between IS and traditional research is that it is heavily framework driven, again, as opposed to being hypothesis driven. We can go on to the next slide. So why care about implementation science? Well, as many of you know, clinical innovations are very difficult to implement. And so I think we need a better toolbox, a better skill set, one that is rooted in evidence, to really make sure that complex interventions such as those aimed at addressing health inequities, really have their best shot at being implemented. We know that clinical innovations that are top-down initiatives are rarely sufficient. We know readiness is a major factor, and differs not only across different sites within an organization, but it can also differ across time. It requires participation from multiple stakeholders, and achieving consensus amongst multiple stakeholders is, as many of you know, oftentimes a very significant challenge. And we can use whatever tool that's available to us to do better at that. Specifically within healthcare, and especially these days during the pandemic, providers and staff are overworked and have limited bandwidth. So we really need to measure twice and cut once, because we have limited opportunities to insert an intervention or try to implement an intervention with folks, the workload that folks have these days. Education alone is rarely sufficient. It's important, but it is by no means sufficient. So pamphlets, even educational apps, I'm going to go ahead and say rarely work. And this is backed by a lot of evidence. So we really need more than what we're accustomed to. Next slide, please. How do we do it? So you can move on to the next slide. As I said before, implementation science is a framework-driven discipline. And what I want to do over the next few slides here is discuss how successful implementation is done, and by really focusing on one particular framework, the IPARIS framework, developed by Harvey and Kitson. IPARIS refers to the Integrated Promoting Action on Research Implementation and Health Services. And it defines successful implementation as a sum of the innovation plus the recipients plus the context, all as a function of facilitation. And if we move on to the animation, in other words, success is the what, the who, the where, and how all of that together is done. We can move on to the next slide. So let's start by talking a little bit about the innovation. An innovation here, by the way, can be a program, it can be a practice, it can be an evidence-based process, a policy, guideline. It doesn't necessarily need to be something new. If a program, policy, or guideline, for example, happens to be new to an organization, then that can be considered an innovation. In order for us to be successful in implementing, we need to consider the following about the innovation and really make sure we understand these dimensions on the front end. We need to understand how complex it is to implement. We need to hear from folks the relative advantage of this new thing over what's existing. We need to understand the usability, and oftentimes the evidence can be very compelling for people to adopt the intervention. Again, the evidence can be research-based or it can be experiential. The context gets at the where. So where is this innovation being implemented? The location in which you're trying to deliver this. It can be at scale across a large organization. It could be within one practice or a handful of practices, or it can be within an exam room. Again, really focusing on the context, I think, is one of the things that implementation science really equips us well to do. The inner context. So let's start with the inner context. In order for us to be successful, we really need to understand the leadership support. We need to understand the culture before we go in. We need to understand what organizations have as priorities. We should have evaluation and feedback processes in place. And oftentimes learning networks can really be helpful in ensuring that innovation is implemented successfully. Next, we really need to understand the outer context. You can go ahead and click to the next slide. Thank you. So we need to understand the outer context, which again can be focusing on policy drivers, on organizational priorities, incentives and mandates. And then we can't ignore the power that the pandemic has had on all of us. And that is absolutely something that is out of our control and very much defines our outer context. Next, we can move on to the recipients. And again, this not only refers to who is receiving the innovation, but also who will be implementing the innovation. On the front end, if we understand the motivations, if we understand values and beliefs of the recipients, their goals, their skills, their knowledge, how much time these things take to implement, resources and support that might be available for the recipients to implement this. This is especially important in healthcare where everyone is so overworked. We need to understand local opinion leaders because they can have a very strong influence as to whether or not something gets adopted. And then understanding power and authority. These are all factors that may seem daunting, but are critically important for us to understand before we go into an organization and expect folks to adopt the innovation that we're promoting. And then you can click once more. And the point here is that not only do we need to consider all of these factors, but we also need to keep in mind that these factors are dynamic and interrelated. And so even if, for example, an innovation can seem fairly straightforward, if the context is one in which the practice is overworked, or they've been burned in the past by a similar type of innovation, or the recipients don't have the wherewithal, then no matter how simple the innovation may seem, if we ignore the context and the recipients, then we run the risk of not being able to get to where we want to get to with implementing the innovation. I want to just talk a little bit about facilitation, so we can move on to the next slide. Only to note that, fortunately, there is a toolbox to draw from, an evidence-based toolbox to draw from. The heroic efforts of this team of Powell and colleagues went ahead and put together and identified 73 discrete evidence-based implementation strategies. So this is the how to go about what are the strategies we should use that have already been shown to implement things successfully. And one of the points that the authors really emphasize is that these evidence-based strategies can and should be used as a bundled set, as opposed to just one or a singular approach. And this is again one of these instances in which we differ significantly from what we think of typically as traditional research, where we're often trying to identify and isolate the causal impact of one thing. Here, we don't care about the causal impact of one approach or one intervention. We know these work. So we're really ready to throw the kitchen sink at it, and implementation science says, do so. Grab as many strategies as you need and throw them against the wall, because they've been shown in the past to stick. Move on to the next slide. And this is just to kind of reorient us as to where we are. And what I'd like to do is just kind of talk a little bit about some takeaways and tag in Craig here in just a minute so that we can leave some time for questions. So we can move on to the next slide. And again, these are just things that I hope will be useful for the teams over the next couple of days and the weekend as they're thinking about their solutions. And again, this is deliberate to the repetitive nature of the presentation. Given the difficult challenges that we're trying to tackle, I would argue that a multi-level approach is critically important. I challenge folks not to shy away from nuance and complexity and to address it head on. I challenge folks to dig deep into context, to understand nuance as opposed to trying to control for it. Again, want to just remind people that the context and the recipients are as important as the innovation itself. So yes, most hackathons focus on the solution, but what I am challenging folks here is to similarly think about the people who are both delivering and receiving, as well as the context within which they're delivering and receiving these innovations. Want to put in another plug for frameworks. They're helpful in making sure that we're keeping things in mind on the front end of designing the intervention, as opposed to stumbling across this as we often do during the implementation phase. This is a little tongue in cheek. I'm saying no more apps, please. You're welcome to design apps, but the point here is, education isn't alone. Apps, we know in and of themselves will not be enough to move the needle, especially with the nature of the work that we're trying to take on here. The next slide is to try to just maybe tee up or provide some targets for folks to think about in terms of solutions that could be useful. We know that doing rapid assessments of context, of understanding local culture and understanding the recipients, understanding organizational structure is difficult. It's complex. There aren't enough existing purely quantitative data sources to help us put that picture together. And so perhaps something that folks can consider as you're designing solutions are tools to enhance our ability to collect this qualitative data so that we can really quickly get an understanding of context and culture and organizational structure. Too often the methods that we use are quite labor intensive and tedious. So I challenge folks to think about that. And as a sort of segue for my colleague, Dr. Craig Munson here, also will challenge folks to think about ways to leverage existing data sources, specifically with an eye towards understanding the patient population and their specific needs, and in particular, the health inequities that patient populations are facing, and how do we quickly understand what those are and who these patient groups are. And that is something that I think the data streams available that out there that Craig can talk a little bit with us about might lend themselves to. I will tag my colleague Craig Munson in next, and towards the end we can leave some time for questions. Thank you very much.
Great, thank you. That was great. All right.
Thanks, Susanna, for pulling up the slides there. And while you're doing that, let me thank John for teeing this up so nicely. Actually, despite what you might guess, given my work in informatics, working with applications, working with data, I'm going to say the same thing. No apps, please. Somewhat tongue-in-cheek, but I think that really, as you are thinking about what's possible and how do we address some of our challenges, I want to encourage you to continue to think about that context, think about the innovation, think about the recipients, and really digest it within the frameworks that John has laid out here. That said, I do want to equip you with a little bit of the, and perhaps demystify some of the data streams that are available for actualizing our interventions. And I think it's really a nice pairing to talk about informatics within this context of implementation science, because it is frequently through that pairing of the qualitative analysis and understanding of those factors and the quantitative analysis that implementation science can really be done pragmatically. And oftentimes, the implementation science, the evaluation is for an explicit informatics intervention. So for those two reasons, I want to give you a little bit of additional color on what informatics in a healthcare organization like Atrius Health looks like. Next slide will help tee this up a bit. I think in addition to avoiding the, all apps as kind of centerpiece of a solution, this kind of speaks to some of the points around context of where we are today. What makes it challenging to work in informatics and build out technological facilitators of what are really people, process, and technology solutions. So today, in our current state, we have a lot of different information systems, the familiar electronic health record type stuff on the bottom, but then things that are more cutting edge. How do we collaborate effectively with partners outside of our organization? Where do apps fit in? So-called patient-generated data like fitness data, nutrition tracking, and so on. Well, right now, in order to work together, each of these arrows represent point-to-point data interfaces that need to be created. And that really slows things down. If you imagine the breadth of data sources that need to be brought together in order to begin to capture the fullness of a person and their life experiences, you can quickly come up with the need for integrations of, on the order of 10 to 20 different types of interfaces just to get started. And that's not really conducive to innovation, obviously. In the future, we will, through some of the technologies and standards that I'll share in a moment, be in this place where it's much more straightforward to bridge the gap, bridge the systems through which these different data, or where these different data live. But it's really, I think, up to us here, up to you guys as participants, to begin to think about what sort of enablers are most important there, and then how do we get there. So the next slide is just a word of caution along the lines of what John shared. In a weekend, I think it's unlikely that you'll be able to get into great depth here of either of these or all of these technologies I'm about to share. But again, for your planning and context, you may choose to dig into them a little bit more. So there are a lot of links here that obviously we won't go into today, but I wanted to make them available for you as you consider with your teams what might be relevant to the solutioning that you're doing. So next slide is an introduction to, first we'll start with clinical data, and then we'll talk about administrative or claims data. I think the centerpiece of information exchange for clinical data is really, there are two buzzwords, and they're paired in this phrase, smart on FHIR. I'm going to start by explaining FHIR, which stands for Fast Healthcare Interoperability Resources. And I describe them as loosely standardized or open source portal of entry for access to data. And this is really important because, in contrast to the point-to-point system, this set of standards really begins to define a way to incorporate data from any clinical data source. So electronic health records are kind of like the flagship here, but that also, you'll see in a few minutes, applies to claims data. It borrows from web standards. So if you're familiar in developing web-based RESTful interfaces, they generally look like this URL here, where you have a base, which may differ from organization to organization, but the remaining, the patient identifier, this note about their history, is all standard. So you can essentially drag and drop that URL to a new system and get, obviously different information if it represents a different system, a different patient, but you can kind of program once and deploy many folds. You'll see why that's important in the next slide in a moment. But you can see, in addition, what you will get back is, or what you do get back from these FHIR standard application points or programming data points, is a standard set. This is JSON, JavaScript object notation. XML is also available to be able to programmatically process the data comes back. And this is just what a patient data element looks like when you make that request through the FHIR interface. The other thing to note about FHIR is that it represents not just a agreed upon mechanism to request this data, but it also defines, what do we mean by healthcare data? In other words, the data model. So it includes these quote unquote resources. And here I'm just illustrating from the FHIR specifications the relationship that exists within FHIR. It begins to describe important concepts like patients, procedures, reports, conditions. And in fact, there are dozens, if not now hundreds, of resources available through the FHIR standard. And it's still being developed. So it's been in development now for about a decade. Only in the last 2 years is it now a normative standard that you can access through any electronic health record. So it's a very exciting time to be developing cross-application or cross-platform applications. If we go to the next slide, so that kind of speaks to the data and how they kind of pass from one to another. But there's an important piece of this as well, which is, what's the front end that people are interacting with? And, we've all used our smartphones or computer applications at this point to appreciate that there's something that's missing from the electronic health record platform and from clinical data generally. And it's the ability to port, from one device to another or from one platform to another, the same application. So if you have the data part solved, there's still a missing piece about how do I get this application from my Epic electronic health record to my Cerner electronic health record to my Meditech health record, or for that matter, from one Epic health record to another Epic health record. And so as you can see illustrated in this picture on the left here, there are this conceptual idea of the kind of app store for clinical applications. And the way we're doing that as a kind of healthcare system is through the adoption of this SMART technology. That's also a set of standards that handles things like containerizing a web-based application or passing patient context through those FHIR APIs or authenticating a user, which is very important, especially in healthcare where really only certain folks should have access to the patient data. And then on the right is an illustration of this app store concept. So this is the Smart App Gallery that you can explore on your own through the links here, just to get a flavor of what already exists and what developers have already done to prepare cross-platform, cross-electronic health record applications. Next slide. So this is more of a reference. I don't intend to go through it. What I'll call out though is about 5 lines down. What I want you to know generally is that these capabilities exist today. And if you want to explore them, I encourage you to start at the Get Started link. If you really just want to see how it works, you might try the second link. I focused down with some of the resources here into, okay, you want to learn about FHIR, you want to learn about SMART, what does it look like in Epic? And ultimately, what does it look like for an organization like Atrius Health? So that 5th row down, if you'd like to see what Atrius Health's FHIR capabilities are, you can go to that link there, and that's really our base URL. But there's, in fact, a link earlier to the FHIR directory. You could see what those base URLs look like for healthcare systems across the country. Next slide, please. Okay, so then we transition to claims. And, I haven't seen a claim like what's illustrated on the right here since maybe 2004. So I only raise it here as an illustration of what sort of content is available in administrative claims. And I think it's a really important point. If you haven't yet worked with claims, as you might imagine, it's great about understanding the pieces of, it is the process by which healthcare services are adjudicated and paid for. So it's very accurate with respect to services that are paid for. It is less accurate for the components of care that are not paid for, billed or paid for. And given the increasing amount of asynchronous, for example, secure message-based care, there are big gaps in what claims data can tell you. But here's what they do tell you. They tell you information about a patient, their coverage that's available, including what plans they belong to, the services that are offered on an encounter-to-encounter basis, and finally the charges. So they are the source of truth, bar none, for any sort of charge and cost information for healthcare. Because they are the process of a rather extensive administrative process, even fair to say negotiation between providers of healthcare services and payers of healthcare services, they experience a significant lag, which is another important limitation that in general, an organization like Atrius Health, we're not confident about what has been paid for or what the cost of care is with less than a 90-day lag. In other words, relative to what comes through the electronic health record information, that clinical information, when it comes to understanding costs of care and the kind of end results of these administrative processes, that's often lagged by 3 months typically, and it could be as long as 6 months. Other things to know about claims is that they are heavily coded, so perhaps a relic of our paper-based system in the past, but whatever the reason, our services are coded into an important CPT language, these 5-digit codes that represent the services being offered, such as an evaluation visit or a colonoscopy would each have their 5-digit codes. And then the ICD-10 diagnosis codes, which reflect the diagnoses or conditions that have been, the services are being offered to manage. And for the reasons I kind of illustrated, the information is often very complete in some areas and less complete in other areas. The reason I mention this in the context of our efforts to improve health equity is that information about a patient's race, ethnicity, preferred language, gender identity may not be a part of the administrative process for review in order to bill a service and get paid for. At best, legal sex is used to confirm a patient's identity to match coverage, but when it comes to accurate ethnicity data and claims data, well, that's a gap, let's just say that. So that's, I think, what I wanted to share as far as the kind of anatomy of a healthcare claim. The next slide illustrates a little bit more contemporaneously what claims look like. So these are now shared with us as an organization like Atrius Health. For our membership, we will receive from payers, including Medicare. Here's an illustration on the right of the relationship between the many files that Medicare passes to us in order to understand the cost of care. That's with all the caveats I described around claims lag and incomplete data and the like. But it truly is the authoritative source for understanding admission and cost information, as I suggested. I wanted to illustrate, to the point I was describing towards the end of the earlier slide about data availability, is that even when data are available, they may be somewhat limited in what they provide. So here, intriguingly, is Medicare's description on the bottom right of the beneficiary race code. And you'll notice, somewhat oddly, it incorporates race and ethnicity concepts both into one. For example, if you look at OMB recommendation or OMB standards, Hispanic or non-Hispanic would be the kind of preferred ethnicity representation. But here you could kind of appreciate that you're really only getting one field for that in claims data if it's complete at all, which then starts to create issues. Okay, well, what if you're interested in understanding, patients who self-identify as, let's say other for their race, but Hispanic for their ethnicity? This doesn't really capture some of the nuance there about how patients identify. So another gap I just want to ease you with to some extent. The next slide is along the lines of what we're discussing in the clinical data. So suppose you wanted to hack with claims. I first advise you don't bother, partly for the reasons I was just describing around the availability of health equity related dimensions, but also the availability of the data itself is really challenging. I mean, these data are principally used to understand the cost of care, which itself, though there have been increasing regulations and movement to provide greater transparency into the cost of care, we're still not there yet. And as a result, there's a fair bit of contractual limitations in how data can be shared, when they can be shared, and the specifics of which data are shared. So I recommend, if you're remotely interested in the type of data that claims data represent, to go to the CDC and look at their NAMP data set. And I provided a link there. It really is comparable. It is also nationally representative. There's a neat sampling methodology, and I highly recommend it. I also mentioned earlier in the introduction to FHIR that in addition to use for clinical data, there is a pilot underway that Medicare is advancing to enable the same technologies to pull claims data with that base URL concept that I was describing earlier, which is a really neat idea to be able to avoid the multiple different files and relationships that I shared in a slide, or a couple of slides ago, and again, kind of build once and deploy many different ways. And finally, this one I kind of shoehorned in, but since I was describing it in an earlier slide with respect to claims, I wanted to point out the OMB's minimum standards for identifying elements of race and ethnicity, which, as we know, is only one important dimension of patient identity and equity. So it's TBD, I comment about what standards for gender identity and other components of individuals' identity, patients' identities, what we're often most concerned with, and how to represent that so that we can speak the same language when attempting to close those equity gaps. So the last slide, I just want to leave you with a couple of questions really to consider as you're hacking, if you're so inclined to consider the informatics lens. And the first is to borrow from our Office of the National Coordinator, which concerns itself with how our data and our electronic health records, the systems for providing care, how are they developed and what are they certified to include? And ONC introduces this idea of incorporating equity by design into our information system. So I ask you to consider, what does that look like for incorporating equity by design into our data information systems? And then, of course, the perennial challenge: how do we get from here to there in terms of what are the key pieces and standards that need to be in place? Who's responsible? How do we pay for that? As there's often significant effort into changing past systems to reflect our values and insights of today and keep them forward compatible for tomorrow. So good luck. It's a tall order. I look forward to what questions you might have and learning about the great solutions you come up with.
Thank you so much. Both of those presentations were great, really informative. So people can put questions in the chat, or just unmute yourself and raise them.
I see one question emerge in the Q&A, and I think we are appreciating that participants may not have the ability to unmute. So please type your questions in the chat, and maybe in the meantime, we'll figure out if there is a way to unmute. But Martina asked the question, are there attempts or needs to capture multiracial information? And I think that really speaks, Martina, to that question is, what does equity by design look like? I think from a needs perspective, I'm guessing here, though I invite, additional thoughts about what that might, well, I would say the answer is yes. How do we get there becomes a separate challenge, and that might be an interesting area to explore. As far as what attempts there are to capture multiracial information, it's interesting because oftentimes you get pretty pedestrian in the considerations about, is this specific web form a multi-select or is it a single select? And frequently, as you saw from the coded information from that Medicare example, you can only have 0, 1, 2, 3, 4, 5, or 6. You can't have 0 and 1 or 2 and 3. So I think, yes, there's a need, and yes, we will, and there are efforts to capture multiracial information, but I think I haven't seen coordinated efforts to ensure that's being done across the board. I'm wondering if this is a good one for you from Forrest about cross-sectional support, cross-disability statuses in combination with race and gender. What sorts of frameworks can be helpful looking at capturing those sorts of intersections?
Yeah, thanks for the question, Forrest. And I was just trying to think about what types of, in implementation science, there are roughly 70 or so frameworks that are like published and have a prominent place in the literature. So my gut is that there probably is a good framework that can help you kind of crosswalk these two types of data. I can't think of anything specific off the top of my head that I know would fit this stuff. So I would certainly encourage you to look. The Implementation Science Journal, it's called Implementation Science, is very sort of academic and very much a repository for frameworks and for, it's sort of the place where frameworks are born. This particular journal. So I would encourage you, Forrest, to have a look at that journal.
I'll comment as well, just, unlike the race and ethnicity gaps that I mentioned, disability status is an important administrative data element as it determines eligibility for various social support programs, often state social support programs. So I suspect that there's actually pretty complete data about, at least for those who are kind of receiving disability benefits. I do believe in Massachusetts, there are efforts to ensure that there is effective and appropriate data sharing about disability status. For example, it is an important element used for our participation as a healthcare provider in our Medicaid ACO, value-based care participation, identifying which patients may be benefiting from additional social supports based on their disability status. But I'm not aware yet, although I think certainly our friends at Mass Health have indicated that there's ongoing interest to capture that important other dimensions of equity, that is race and ethnicity, as robustly as, for example, disability status. Yeah, so Jonathan, I hope I pronounced that right, asked the question about having better, healthcare organizations have better handoff in patient claims data. Do we expect any improvement in that 3 to 6 month lag? And is it beyond technical concerns? It's a great question. I would say that there is promise, though it's probably a ways off, about streamlining the administrative handoffs that occur between healthcare organizations and payers. It does kind of, and I'll invite John if there are implementation science connection points to this, but from an informatics lens, there is somewhat famously a Medicare requirement for decision support for advanced radiology studies. In other words, providers indicate in their orders for a CT scan or MRI the indication for that particular study. And decision support comes up and says, you ordered a head CT for someone who really has just had a headache for a couple of weeks. That's really not the appropriate indication. The reason I mention that is that though it has not yet been the case, or even proposed for that matter in regulation, it's been considered that that might be a precursor to authorization requirements and streamlining some of the prior authorization steps and the administrative oversight that health payers provide could theoretically be streamlined by passing that data back and forth more efficiently. So I think that's what you're alluding to in part, is that administrative simplification and reducing administrative burden through better data exchange. I think we're still a long ways off from that, in part because of standards, in part because it takes some time to figure out, okay, even if we have the right standards, what sort of logic do we really need there? And so, I would say we're probably 5 to 10 years from reducing the administrative claims lag that would be downstream of more effective authorization and payment.
I'll zoom in and sort of, chime in and zoom out to say that I think you're right, Jonathan. I think your intuition is right in that the root is probably beyond the technical concerns. There are certainly technical concerns, as Craig is pointing out, but fundamentally, few payers are going to want to, on their own accord, be transparent about how much they're paying or what kind of quality, of care, the quality of the care that they're providing or facilitating for and then show the associated dollar signs. I think we're going to get close to that though, because there is a very strong push towards increased transparency. We're seeing this now with the Cures Act and the push for immediate release of results. That's something that is a step in that direction, or an appropriate step in the direction of transparency. And so my sense is that better transparency around how much things cost and how we bill and code things will also become more and more transparent, is my sense of things.
Just pause a bit in case people are typing some questions.
It looks like Jonathan has another question, and I think it relates to a point, John, that you just made of basically what can be done incentivizing hospitals to make patient data more available for various use cases. And I think I would just pick up the thread of what, John, you already shared, that I think the main mechanism by which that happens is through regulation. Unfortunately, many of the regulations that exist to enable healthcare players, whether that's payers, providers, pharmacies, pharmacy benefit managers, you name it, to cooperate and exchange data can sometimes be misinterpreted. So HIPAA is a great example where I think by virtue of folks' kind of colloquial familiarity with the regulation, you might guess that the P, first of all, there's only one P in HIPAA. The P in HIPAA stands not for privacy, as you might guess, but for portability. And really, the regulations are designed to encourage data exchange. But as John shared, it was only quite recently, as recently as June 2020, and there are a number of regulations still in the works to encourage healthcare stakeholders to open up data, not even necessarily to release them in a de-identified form, but to make them available through patient-mediated exchange. And that's the most challenging part, I would say, is exchanging the right data with full patient-informed consent and authorization. So even, with the great kind of technology of FHIR and all that stuff on the horizon, there's still a very important step of patient authorization to do with that data what the patient wants, as though, as kind of seems, in some sense natural, the patient is the owner of their data. And there's always a risk with kind of a de-identified health data set that someone comes in and identifies the health data, or that even a de-identified data set or even a partially identifiable data set is used for purposes that the patient, had they known, would really prefer they not have been used. And so I think we have some work to do, and in fact, their effort of not just the Office of Civil Rights through HIPAA and the ONC and CMS through information blocking regulations to open those things up, but also importantly from the Federal Trade Commission to ensure that when the data leave, a payer data set or a healthcare data set, that the interests of the patients are protected. So there's a fair bit of work, and I think there's something like $1 billion proposed to bulk up the FTC to ensure that those patient data rights are protected. But it's a challenging thing to solve. Some patients may really want their data to be used for research purposes or public health purposes, and some may not. And that's probably the most important compass we have in determining how data are used, is what do patients want? So Martina asked a question about having a clearinghouse for healthcare data and on what timeline. And I would say that's a deceptively challenging question. It's a simple question with a challenging answer, because it kind of depends in large part on the data. But if I could, like, very conceptually and at a high level say, will there be a clearinghouse for healthcare data? And I would say, you know, I don't want to get like too in the weeds here, but that might mean two things. It might mean there's a single kind of central repository of clinical and administrative data that are available and can be tapped into for, you know, an arbitrary purpose. I don't think that will exist in the US. The model that seems to be gaining more traction is more of a federated data model, where there are stewards and stores of data. Different players in that might be a specific payer, and they might be specific providers that, again, are stewards of data. But then it's really the network. I think, you know, clearinghouse can mean a health information exchange network, and those are all over the place. I mean, just within Massachusetts, we have a state health information network. We have at least 4 or 5 prominent vendor-specific health information exchange networks. We have multiple commercial clearinghouses, including a state-specific one, New England Healthcare, or a regional specific one, New England Healthcare Electronic Network, Exchange Network. And so almost the problem is, you know, we have a lot of clearinghouses. So maybe in kind of central to your question is, will we ever have one? And I would say, no, we will probably not ever have one. But what I will say, and what I'm personally very excited about, is really a federal effort to create standards for how those networks exchange data as a network of networks. And the kind of acronym to tune into on that is called TEFCA, for the Trusted Exchange Framework and Common Agreement. That's not actually a set of technologies. It's really an agreement, a contract, rules of the road, if you will, for what data do we exchange and how. So paired pretty nicely with that, and I think relevant to our conversation about health equity, is the TEFCA, the agreement about what can be shared, by whom, for what purposes. There's enforcement activity, and there's a specific organization that's responsible for implementing this, called the Recognized Coordinating Entity, and they're called Sequoia. And they will set the rules for this network of exchange. So I think we will effectively get to a clearinghouse, or if you will, a single on-ramp to interoperability. You know, that's the future in that second slide I shared, or first slide I shared. But I also want to say, in addition to that framework for exchange, and paired up nicely with FHIR, is what do we mean by any of these different concepts about a patient? And so working hand in hand with Sequoia, our federal Office of the National Coordinator, who sets the standards for what has to be included, at least in electronic health records, although increasingly they're de facto setting the standards of what needs to be included in payer, that is, insurer information systems as well, what data appear there. And just recently, they've announced their intent to include not just race, ethnicity, preferred language information, but also gender identity information, as this is part of the base set of information that needs to be exchanged. And that goes through a whole kind of regulatory process, comment and response. And in fact, it'll probably take a year just to go through that process, and another 2 to implement across health, or rather information systems. So maybe that helps give you a sense a little bit of some of the timing in all of this. But different pockets will have that information more so than others. And, you know, directionally, we're definitely headed in that direction.
All right. Thank you so much, Dr. Monson and Dr. Zambrano, for your time. This is really, really useful information, and this is these are great questions from the participants as well. So I thank you all. Have a great rest of your night.
Have a good night.
Good night, everyone. Good luck.